So how long? So I would say we do reproductive system today, Wednesday, and Friday. So at least 2 sections for the reproductive system. It is like it's not just the reproductive system. We include some embryology, so the way the human fetus is formed and gradually developed, and at the same time there are a few little things which we haven't talked about when we were talking about the anterior abdominal wall. So I am going to include these embryology, the development of the fetus, and some part of the anterior abdominal wall, which is around the groin, so inguinal region. So this inguinal region anatomy is pretty important, let's say, because it is associated with the inguinal hernia. So inguinal hernia, I believe you must have seen or hear about these inguinal hernias. So this inguinal anatomy is important, like because it is in our groin, and therefore we have to talk about that a little bit more detail. So it is a little bit more detailed anatomy of the anterior abdominal wall. So we'll take time, we'll take today and Friday talking about the reproductive system and including these. And if necessary, we will continue on Monday as well. So like Wednesday, Friday, with or without Monday, right? We talk about this reproductive system. And on Wednesday next week, I just wonder if we do lower limb muscles, if we can. If not, we can do the revision for all the subjects we have studied. And on Friday, next week, Friday, not this week, next week, Friday, there will be no class. I will just give everyone a break. You know, I just want you guys to do whatever you like on next week, Friday, not this week. This week is reproductive system. Next week, Friday, we talk about that. There will be no class. Just, I want you to enjoy, finish all the homeworks. And yeah, so let's do that. So reproductive system, like we have seen this slide already. It is a female internal reproductive organs, which is the uterus, the big uterus, and it is the tube which is coming into the uterus. It is on the right side as well as the left side. And this tube is called fallopian tube. This fallopian tube, it's just, it was pretty much dilated at the beginning, and gradually when it comes close to the uterine cavity, so this is the uterine cavity here, and this is the wall of the uterus. And if you look at that, you know, this fallopian tube is pretty wide at the beginning and gradually get smaller and smaller and smaller. And when it is very close to the uterus, hey, it is pretty narrow, and now then it leads into the uterus cavity. This uterine cavity has how many layers could it be? If you don't know, just say 3, yeah? So everything in life is 3. 1, 2, 3. So how many layers are there in the uterus? I want you to say 3. Hey, only one exception, which we have seen. It is the gastrointestinal tract, which has got 4 layers. Yeah. So uterine cavity has got 3 layers, which is innermost is endometrium, like endothelium for the blood vessel, and epithelium for the gastrointestinal tract, and for the uterine cavity, endometrium, innermost endometrium, which is written here, endometrium, which is close to the uterine cavity. And that will be covered by the smooth mast cell layer, which is the myometrium, M-Y-O, myo, mean mast cell, myometrium. And the outermost layer, as you can see here, it is the around the uterus. So we will say perimetrium. So now three layers. Our uterus has three layers, which is the endometrium, myometrium, and the outermost perimetrium. And this is the inner uterus cavity. And this portion of the uterine cavity is called cervix. I believe we all know that. Cervix, and then uterus cavity that will be coming from the fallopian tube. And I want you to appreciate fallopian tube is pretty wide at the distal. And as it approaches to the uterine cavity, the fallopian tube gets smaller and smaller and smaller. And of course, when it is crossing the uterus myometrium, it might be the narrowest portion of the fallopian tube. And if you look at that, the widest portion of the fallopian tube, which is finally just like a fingers out projection here, finger out projection here, these are called fimbriae, yeah, F-I-M-B-R-I-A-E, fimbriae, like a fingers like coming out at the end of the fallopian tube. So this is the, let's say this is the right fallopian tube. We have the left fallopian tube there, and fallopian tubes at the end, we have a finger-like projection. These are called fimbriae. So what usually happens is in a normal reproductive age, in a fertile woman, a fertile lady, this is their ovary. So right ovary here, there will be left ovary here. Every month, this ovary will just spit out a little ovum, little ovum outside of the ovary every month. That is what we call ovulation. So ovulation usually happens mid-cycle. So let's say if a lady has 28 day cycle, then at the day 14, usually this little ovary got mature from the ovary, and this little ovum pop out, pop. And then that's pop out, this little ovum will be catched by the fimbriae of the fallopian tube. Yeah, so this little fimbriae, like a finger-like structures, will go and trap the ovulated little ovum and we bring it into the fallopian tube. Hey, how wonderful it is. Yeah, so this little ovum come out from the ovary, and then this fimbriae will catch that little ovary and put it into the fallopian tube. Let's say if someone has got sex, and if the sperm go through the cervix into the uterus cavity, the sperm has to go quite a long way through the uterine cavity and has to go along the fallopian tube, and the sperm and that ovum meets. That is what we call fertilization. Yeah. So usually, if we divide the fallopian tube into three portions, let's say medial 1/3, middle 1/3, and lateral 1/3, this fertilization usually takes place in the lateral 1/3, outer 1/3 of the fallopian tube. So, which means the sperm has to travel through the cervix, inside the uterine cavity, go along the fallopian tube, go first third of the fallopian tube, second third of the fallopian tube, and at lateral 1/3 of the fallopian tube, that's where the sperm and ovum meet, and they form they get the fertilization. And if you keep looking at that, this oocyte, egg, will meet the sperm, get fertilized, and this fertilized initially, of course, only one cell, and that will divide into two cells. 2 cells will divide into 4 cells. So like 1 here, and then become 2, and then become 4, and become 8. So as this little fertilized ovum gradually divides, and it takes about 4 days for this fertilized ovum to reach into the uterine cavity. So it is quite a long time, guys. You know, it takes about 4 days to, like, if you check your body, how wide your pelvis is, and just imagine how long should your fallopian tube be. So it might not be longer than this 1 finger, but that takes about 4 days for the fertilized ovum to travel from the lateral 1/3 of the fallopian tube along the fallopian tube to get into the uterine cavity. Hey, whatever it is, at the day 4 is in 4, day 4, this fertilized ovum gets into the uterine cavity. It is wonderful. Yeah, it is wonderful. So it is not easy to be a human being. Yeah, you have to take a lot of chances. A sperm and ovum has to meet and get fertilized, and it takes easily 4 days for a long. It is a long trip, but it is just about this length, 1 fallopian tube from the lateral 1/3 to get into the uterine cavity. Whatever it is, along its way from the lateral 1/3 of the fallopian tube, middle 1/3 of the fallopian tube, medial 1/3 of the fallopian tube. As you can see, from 1 cell to 2 cell, 2 cell to 4 cell, 4 cell to 16 cells, 16 cells to everything, and then gradually it gets into, before it gets into the uterine cavity. Let's say at the end of day 3, at the beginning of day 4, there will be about 60 cells, 60 as in 6 and 0 and 6 and 0, 60 cells. So day 3 is called morula. So morula stage might be about, let's say, 16 cells, and that is day 3, and it is just about to come into the uterine cavity. It will take about, from here to there, it will take about 1 day, 24 hours to get from here to there. And during the time, this morula, M-O-R-U-L-A, as you can see, morula, which is about 16 cell stage, we have to become about 60 cells. So when it gets into the uterine cavity, it is about 60 cells already. And as you can see, when it is only 1 cell, it is pretty big. And when it gets to the 4 cells, the cells are gradually smaller. And when it gets to the 16 cells, the cells are even smaller. So the cells will gradually get smaller and smaller to make the size maintain here. So if you look at the whole size of this, let's say it is a coin, 1 coin. This coin is equivalent to this coin, and equivalent to this coin, and equivalent to this coin. But the cells inside the coin will gradually get smaller, and smaller as they multiply more and more number, increasing number. So, hey, you know, like 4 days, it gets into the uterine cavity. And once it gets into the uterine cavity, hey, there are lots of fluid inside the uterine cavity. Let's remember that way. Yeah, so there are a lot of fluid, juice in the uterus cavity. And therefore, this little cell, like a little ball cell, once it gets into the uterine cavity, it will suck all the fluid from the uterine cavity. And then now, look at that. The little cell, which is filled with all the cells, now, because it's absorbed fluid from the uterine cavity. And so the 1 portion is filled with fluid, and the rest of the cell will be pushed into 1 corner. Yeah, I believe you got that. So this one, until morula, before it enters the uterine cavity, it is filled with cells. once it gets into the uterine cavity, it absorbs fluid from the surrounding environment, and that fluid will remain inside the cell and push the remaining cell to one corner. Now, this fertilized ovum has become one portion is filled with fluid, the other portion is filled with the cells. Hey, because it is containing fluid, and we have to say like a little bag, a bag in the other Greek called cyst. So now this cavity filled with fluid is called blastocyst, and the other cells which remain as cells, it is called the inner cell mass. So this inner cell, hey, let's look at that here. Now it is better seen now. The whole cell, the one side which is filled with the fluid is called blastocyst. Cyst means fluid-filled sac or a bag of fluid. And this one portion is called blastocyst. Blastocyst. And the other portion, the cells being pushed to one corner, is called the inner cell mass. Inner cell mass, hey, it will develop into human beings like you and me. So it is strange, you know, like when these all little cells will become the human body, and this is the fluid-filled sac. And so we would say the inner cell mass, blastocyst cavity, and this is the blastocyst. So this happened at about day 4 when it gets into the uterine cavity. Of course, from day 4 to day 7, you know, this little fertilized ovum, which is what we call blastocyst here, blastocyst, this little blastocyst, which is made of blastocyst cavity and the inner cell mass, it is just wandering around in the uterine cavity, and it is just trying to make a decision where to go. And let's say, you know, if the condition is not favorable, it will come out through the cervix and come out from the vagina as the so you lost a fetus. So usually it was just wandering around inside the uterine cavity for about 2, 3, 4 days, 2, 3 days. Usually from day 4 to day 7, it is wandering around. And usually at the day 6 now, day 6 days after the fertilization from here, and it's just going to attach to the endometrium and gradually invade into the endometrium. And this attachment of this blastocyst, which is the fertilized ovum, into the uterine cavity, endometrium, it is called implantation, I-M-P-L-A-N-T-A-T-I-O-N, implantation. So it is like you trying to put the seed into the uterine cavity. And now the fertilization, we get to the stage at the day, let's say about day 7. Day 7 is just go into the endometrium, invade into the endometrium deeper and deeper and deeper. And that process is called implantation. It's amazing. And now this implantation, if the condition is favorable enough for the little fertilized ovum, then this fertilized ovum is going to develop into a baby. So yeah, it is wonderful work. It is wonderful work. So conception means when the egg and the ovum combine, yeah, union of the egg and the sperm. That is what we call conception. And I believe you all know the usual pregnancy is 38 weeks. Yeah, might be plus or minus 2 weeks. So between 36 to 40 weeks, that is the normal pregnancy. After 40 weeks, it is like a slightly overdue. Before 36 weeks, it is a little bit premature. The ideal is within 36 to 40 weeks period. So let's say 30, if the pregnancy, strictly speaking, 38 weeks, for the first 8 weeks, this little conception is called embryo. Yeah. And after 8 weeks, this little conception is called fetus. So that's why, you know, people talk a lot about abortion. Abortion means just like taking the little embryo or the fetus out of the mother's womb, just abortion. Different people have different opinion, and whatever it is very difficult subject to talk about. I appreciate that. Let's say for any medical reason, and if we have to remove this fertilized ovum, I think the earlier we remove, the better, because before it became fetus. Because after 8 weeks, this little embryo is like pretty developed already, like nearly human already. So like the earlier we do, the better. Like I'm talking about medical reason, you know. Let's say if this pregnancy happened, if this mother is going to die, and if we have to remove it, or if it is just a whatever reason, if we have to remove it, the earlier the better, because the first 8 weeks it is called embryo, and second 30 weeks is called fetus. After 8 weeks, that means after 8 weeks, this little concept is pretty much developed already, like it's pretty similar to you and me already. Of course, not quite yet. So that is conception. The embryo, when I say embryo, it is less than 8 weeks. When I say fetus, it is more than 8 weeks up to the labor. And what is fertilization? Fertilization means chromosomes from the male and female gametes come together in the ovum. So fertilization, female ovum has got female chromosome, and male sperm has got male chromosome. They meet inside. So the sperm has to penetrate the ovum and go into the ovum to meet the female chromosome. And only then the sperm will give the female chromosome its male chromosome. And that is what we call fertilization. So a little definitions which I just want you to appreciate, you know, fertilization, conception, embryo, fetus. What does it mean? So once the male chromosome and female chromosome combine together in the female egg, oocyte, that's fertilized oocyte. Once they are fertilized, and that is called the zygote. So zygote is combination of the combined product, let's say combined product of male and female chromosomes. And morula, we saw morula, which is like day 3, is called morula. And at the stage of morula, we will have like about 12 to 16 cells. And late morula, hey, just before it goes into the uterine cavity, it is just getting into the uterine cavity, it's about 60 cells. And it's by at the day 4, let's say, a day 4 morula, and at the day 4, it will get into the uterine cavity and it will change into the blastocyst. So morula stage is let's try to remember, day 3 is morula, day 4 is blastocyst in the uterine cavity. And as we know, the blastocyst because it absorbs water from the uterus, and this uterus will push the cells in one corner. That is what we call inner cell mass, and the fluid portion is called the blastocyst cavity, fluid cavity, and the whole structure is called blastocyst. And this cell, inner cell mass, is something which will develop into human body, And therefore, we will say it is going to be embryo. Therefore, we will say embryoblast, embryoblast. And of course, this blastocyst cavity, the lining of the blastocyst cavity is called trophoblast. A lot of words, you know, like I just want you to listen and appreciate rather than trying to remember in detail. Otherwise, you will just too tense and too, it is difficult, these terminologies. I appreciate that, but the whole structure is called blastocyst, and the fluid cavity is called blastocyst cavity. The inner cell mass, because it is going to become embryo, so we will say embryoblast, and the whole outer lining of the blastocyst is called trophoblast. Tropho means trophic hormone is for nutrition and maturation and growth and that sort of stuff. Trophoblast. Blast means like expanding. So yes, no, you know, at day 4, it is become the blastocyst stage, which is half fluid, half cell. And this from day 4 to day 7, it will be wandering around the uterine cavity and trying to decide what to do. If that little blastocyst come out through the vagina, then that will be abortion. If that little blastocyst stuck to the uterine endometrial wall, and if that invaginates into the uterine endometrium, then that's going to be a implantation. Yeah. So look at that from here, from the ovary, ovulation, oocyte, fertilization, conception, and then zygote come along here, cell divide, come into the uterine cavity, day 4, blastocyst, and then go into the, hey, look at that, this is the uterine endometrium, and this blastocyst is going to attach to the endometrium here. It is just about to attach, which means it is not going to be abortion. It is going to be implantation. Look at that. This blastocyst with the inner cell mass is going to attach to the uterine endometrium. Look at that. Look at that. The cell, the fluid blastocyst cavity and the inner cell mass, which is also called embryoblast. Look at that, you know, these green colored embryoblast, it is the site where it go and attach to the endometrium. It is not on the fluid phase side, it is the cell portion side of the trophoblast, cell portion of the blastocyst, which will go and attach to the uterine endometrium. It is wonderful. It is like going to dock on the uterine cavity. And now, hey, look at that. It is trying to attach to the uterus endometrium, guys. Look at that. And I believe you know everything here. This is the inner cell mass. This is the blastocyst cavity. The whole outer lining is called the trophoblast. Trophoblast. Look at that. The inner cell mass portion is going to attach to the uterine endometrium. It is not the fluid portion attached. It is the cell portion, inner cell mass portion is attaching the uterine endometrium. Hey, look at that. It's gradually invading into the uterine endometrium. This is the diagram, of course. This is the electromicrograph. Look at that. It is amazing. You know, it's just like this inner cell mass portion of the trophoblast is gradually pushing into the uterine endometrium. What I want you to appreciate here is this inner cell mass, you know that, the blastocyst cavity, you know that, the lining, the whole lining is called trophoblast. And this trophoblast portion is gradually expanding like a finger projection, because it has to find a way and nutrition, like the finger, like the way you are swimming, you know, you swim into the, you try to swim into the endometrium, and this trophoblast is gradually expanding, and some of the expanding trophoblast is invading into the uterine endometrium, and this is what we call syncytiotrophoblast. And the remaining trophoblast, which is just covering the cell, trophoblast is called the blastocyst, is called the cytotrophoblast. Hey guys, now we have two types of trophoblast already by just trying to invade into the uterine endometrium. You can see here, when it is just attaching the endometrium, it is just the trophoblast. But this trophoblast, once it is invading into the endometrium, it is just like, like with the finger, like trying to find a way to go into the uterine endometrium. And this gradually proliferate, gradually get more and more. And this invading portion into the endometrium is called the syncytiotrophoblast. And the remaining trophoblast, which is just covering the blastocyst, is called the cytotrophoblast. Of course, there are many names after names after names, because you are not going to remember all these in one go. You will have to repeat that again and again and again. So I still have to repeat this again and again. But whatever it is, I want you to understand, once the blastocyst invade into the endometrium, and then this trophoblast proliferate, and proliferative portion of the trophoblast is called syncytiotrophoblast, and the remaining trophoblast, which is covering the blastocyst, is called cytotrophoblast. Look at that, guys. So the little blastocyst is gradually now going into the endometrium already. This syncytiotrophoblast is proliferating, and as you can see, from here to there, and getting bigger and bigger, and it is trying to find nutrition for this little embryo, like it's just with the finger projection, trying to find a way in the uterine endometrium, and finally it go and attach the blood vessels of the maternal and endometrium. Now this little embryo is going to get blood from the mother. Hey, now success, I have enough nutrition. We have to thank the syncytiotrophoblast, which just try to go and invade and then try to find nutrition for this little embryo. So now we can appreciate the proliferating syncytiotrophoblast, which is gradually bigger and bigger, and finally it reached the maternal blood vessels, and now this little embryo blastocyst is going to get nutrition. And when it is this syncytiotrophoblast is trying to find nutrition and invade into the endometrium, our inner cell mass, the inner cell mass here, this inner cell mass is also gradually changing into two layers. Look at that, guys. So look at one here, the one layer of the cell become blue, and the other layer of the cell become gold yellow. Yeah, so this thick mass will gradually change into two layers, and this blue mass will proliferate cell to this direction and that direction, and the yellow gold layer gradually develop to here, to other side. So everything is doing their own job. The syncytiotrophoblast is invading into the endometrium. At the same time, inner cell mass is also dividing from the solid cell mass and gradually divide into two layers. And this two layer, one blue layer is growing into the other side, and yellow gold layer is also growing to the opposite side and growing to the opposite side. By doing so, this The blue cell, as you can see, it grows to the opposite side and it grows to the opposite side, and it is creating another cavity. Look at that. Now we have another cavity. And at the same time, the blastocyst cavity, which is lined by the cells here, we have another cavity here. Now we are getting two cells layer and two cavities. Hey, this happened at 2 weeks. Everything is 2 now. This happened at 2 weeks. Look at that, 12 days blastocyst. 12 days, let's say up to about 12 days, 2 weeks, 12 days, 14 days, we have changed already. Now, if you look at that, we got two cells layer, which is called bilayered embryonic disc. And we have two cavities here, the blue cavity and the yellow cavity. This blue cavity is called amniotic cavity. Amniotic cavity here, this is the blue cavity. And this yellow cavity is called yolk sac. Hey, look at that. Now we got amniotic cavity and the yolk sac. How does this happen? Of course, you know, this yolk sac gradually developed from the blastocyst cavity, and the two-layer germ sheets go onto the inner side and then become the amniotic cavity. This amniotic cavity is going to be our amnion, water bag. So when a lady gives birth, then this is, you know, you remember the water break. That is the cavity, amniotic cavity we are going to get. It starts from the, you know, very, very little tiny things, and it is going to be a big cavity sac which is going to contain the fetus. That is the amniotic cavity. Look at that, guys. From here to there, gradually bigger and gradually bigger. One during just before the labor, it is really large enough to envelope the little baby to protect any shock. The baby will be floating inside this amniotic cavity. And look at this syncytiotrophoblasts. It is bigger and bigger and trying to grab the maternal blood so that the fetus, little implanted fetus, can survive. And now look at that. This syncytiotrophoblasts is really, really getting big. And finally, it will become the placenta. Yeah. So when you have a baby, after the delivery of the baby, the placenta cord, pull it out, and then finally the placenta will come out. So it is such a big thing. This syncytiotrophoblasts is going to happen. It is going to feed the baby throughout its life. So whatever it is, what we were talking about is at 2 weeks, 12 days. Let's say, don't remember 12 days. Remember as 2 weeks, 14 days. We have two layers and we have two cavities. Two cavities are amniotic cavity and yolk sac. Hey, this yolk sac, what we call yolk sac, is going to become, where part of the yolk sac is going to become our gastrointestinal tract, which we talk about 3 days. It is a long 3 days about gastrointestinal tract. And this amniotic cavity is going to become the amniotic sac, which will keep the baby protect from the surrounding. And keep looking at that, you know, keep looking at that. The surrounding tissue, and there is a chorion. Chorion will be formed around here, around the yolk sac, and chorion will gradually get bigger and bigger. And this yolk sac will gradually get smaller and smaller. Wow. And now we have the two layer, and finally this two layer we gradually change into 3 layers. Now, even at day 16, it is starting to show us 3 layers already. So like from 2 weeks to 3 weeks, that's 2 layer germ disc, embryonic disc is going to change into 3 layer germ disc. So when it gets to 3 weeks, we are going to get 3 layers. So this is the developing stage. It is day 16. It is not fully formed yet. By the end of 3 weeks, we will get 3 layer germ disc, which is what we call ectoderm, mesoderm, endoderm. But at the moment, at 2 weeks, we have bilayered embryonic disc, only 2 layers. And at 3 weeks, we have 3 layer, tri-layered germ embryonic disc. And these 3 layers will be ectoderm, mesoderm, and endoderm, which will develop into like skin, bone, muscles, brain, spinal cord. So all these 3 layers will gradually develop into adult human beings. And so this is what happened here. So now from the implantation stage to 2 weeks, 2 layer, and let's say 3 weeks, 3 layer germ disc, and things gradually change on and on and on. Okay, let's look at this here again, guys. So this is the blastocyst, which is invading into the uteri endometrium, and this inner thermus will gradually change into the 2 layer germ disc. One is blue layer, the other one is the gold layer. This gold layer cells will gradually grow to this side and that side, and finally line the yolk sac. And the blue layer cell will gradually grow to the outwards, and gradually create a cavity, which we call amniotic sac. Yeah. So the cells from the blue, which grow out to form the amniotic sac, let's say it is amnion. Yeah, amnion. Amnion is the lining of the amniotic sac, and the cell which develops and create the amnion or amniotic sac, we will call epiblast. So the blue cell is called epiblast, and the cell which is going to be on the yolk sac here, yolk sac, it is called the hypoblast. Another terminologies come into our way, and we have to absorb the impact. Now we were talking about amniotic cavity, and we were talking about the yolk sac. And now another terminology come in. The cell which create the yolk sac, the lining of the yolk sac, amniotic cavity, is called amnion. And the cell which develop the amnion and amniotic cell is called epiblast. And the cell which go outwards and create the yolk sac is called the hypoblast. So 2 layer germ cell, we will call epiblast and hypoblast. 3 layer, when it comes to 3 layer, we will call ectoderm, mesoderm, and endoderm. So this 2 weeks, 2 layer, these 2 layers are called epiblast and hypoblast. And this epiblast will develop into amnion and create a sac, which is called amniotic cavity. And this hypoblast will gradually develop outwards and create the yolk sac. So this is day 11. It is starting already. By the end of 2 weeks, it is going to be fully developed at this stage. Okay. So bilaminar embryonic disc, which we saw, it has epiblast and hypoblast. Epiblast will create the amniotic sac, we have seen it, and it will also develop into primitive streak. So this is a little structure which we will see in the later part of the lecture. And hypoblast, we know that hypoblast will develop into yolk sac. hey, what is going to happen from the yolk sac? Okay, part of the yolk sac will become gastrointestine, part of the gastrointestinal tract, and blood vessels, blood cells. So yolk sacs we develop into these structures. But at the moment, I want you to remember these two cells, epiblast and hypoblast. Epiblast we develop into amniotic sac, the blue, and hypoblast we develop into yolk sac. What a wonderful world. Of course, finally, our target is to become a little baby. So our target is becoming, look at our yolk sac. You can see that the yolk sac, when it was really big, it started like something like a trophoblast cavity, blastocyst cavity, and this blastocyst cavity and then become lined by the hypoblast, and that is called the yolk sac. And look at the yolk sac gradually become like a little structure, and then just become like a tube. And look at this blue amniotic sac, which is covered by the amnion, which is developed from the epiblast. Look at that, it's gradually bigger, and bigger, and finally it is going to envelope the whole baby, to protect the baby, so that the baby can be floating in the fluid, so that if there is any injury to the tummy, the baby will float rather than get hit directly. And of course, when the delivery comes, this little amniotic sac will rupture. That is what we call the rupture of the water breaks. Yeah, water breaks. So hey, look at that. Finally, this tube coming from the yolk sac, it will become the umbilical cord. Umbilical cord, you look at the umbilical cord here. Look at that. It is amazing. It is amazing, umbilical cord. And this umbilical cord is in continuity with the syncytial trophoblast, which will gradually become placenta. Look at the placenta here. And that is the way we gradually develop. So at 13 weeks after the fertilization, hey, I believe you all know, first trimester, second trimester, and third trimester. Let's say first trimester is about 12 to 14 weeks, and second trimester go on and on. The first trimester, this is the end of the first trimester, and we got a little baby already inside the uterine cavity. Look at that, and uterine cavity will gradually bigger, and bigger. Amazing. So week 3, the formation of the 2-layer germ disc, which we see epiblast and hypoblast. And from week 2 to week 3, it will change from 2-layer germ disc to 3-layer germ disc. This process, it is a process, isn't it? It has to change from 2-layer to become 3-layer, from epiblast and hypoblast to become ectoderm, mesoderm, and endoderm. So it is a gradual process. They take 1 week. If you think about that, this from 2-cell stage to 3-layer stage is called, it is a process. It gradually changes. It just doesn't suddenly like that. So this process is called gastrulation. So if I ask you, what is gastrulation? Hey, Professor, gastrulation means it is a process. It is not a structure. It is a process where our 2-layer embryonic disc will develop into 3-layer embryonic disc. From epiblast and hypoblast into endoderm, mesoderm, and ectoderm. So that process is called gastrulation. So gastrulation, week 3, gastrulation complete. Trilaminar, we got down 3-layer germ disc. And this 3-layer comes mainly from the epiblast. Hey, so where is hypoblast? What happened to hypoblast? Of course, this epiblast will gradually push into the hypoblast and push and change, make the cells change in the hypoblast. And this hypoblast gradually disappear, and this epiblast will come invade into the hypoblast and gradually change become endoderm, mesoderm, and ectoderm. So it is easier to look with the diagram here. So this is the bilayer, two-layer germ disc, two-layer embryonic disc. And if we make a cross section here, this is the two-layer. So one, the blue color epiblast and the yellow color hypoblast. So at this stage, we only have two-layer at 2 weeks. Because of the gastrulation process, it's two-layer, we have to change into three-layer. Two-layer, we have to change into three-layer. And how do they change? As we see here, guys, primitive streak. Look at that. Primitive streak is developing from the blue. Blue is epiblast. Yeah, epiblast is a busy guy. This epiblast will gradually, the cells from the epiblast will gradually move towards the center. So from the periphery, move to the center. From this periphery, move to the center. So the cells are moving inwards and inwards. So let's say, if it is like a tube here, fledged cells here, this is a epiblast. And if they are moving from inside, and this side is also moving to inside, so the two moving inside, now it will make a fold here. So that little fold in the center, because the cell coming from periphery to the center, and it will create a little fold. That little fold is called primitive node, yeah, a primitive streak. And the head portion of the primitive streak is called primitive node, little bump node, yeah, little bump here. And this, the cell from outside and the cell from this outside gradually going into like that and gradually making a fold here. So this peripheral invasion of the cell towards, pushing of the cell towards the center, by doing so, we have a little infolded, which is called primitive streak. And this little primitive streak at the head end is called the primitive nodes. And this epiblast again, it is pushing inwards and it is making another cell, and that cell will gradually invade into the hypoblast. And this new formation of cell is called the ectoderm. Now the hypoblast we have to change into endoderm. Look at here, guys. So it is because of the epiblast which invade into the hypoblast, and this hypoblast have to become the endoderm. Hey, it doesn't stop. Epiblast keep doing the job again and again, on and on. And this epiblast will gradually develop some more cells which will become red color coded mesoderm. And of course, finally, this epiblast itself change into the ectoderm. Now, this process is called gastrulation. Gastrulation is the process which happens from two-layer germ disc gradually changing into three-layer germ disc, and which is the driving force. The driving force is our epiblast. Epiblast will create the primitive streak. Epiblast will create the endoderm. Epiblast will create cell which is called mesoderm, and epiblast will gradually change into ectoderm. Now we got three cells layer: ectoderm, endoderm, mesoderm, and ectoderm. So at 3 weeks, we got 3 layers. So that is the final. There is no more 4 weeks and 4 layers. So because we anatomists, we like 3 layers. So like that is the final stage. So the 2 layer became 3 layer. That is the final. These 3 layers are endoderm, mesoderm, and ectoderm. Right. So now what's happened next? What's happened next? This 3 layer is the driving force for everyone, driving force for you and me. To become you and me, this 3 layer, we have to work hard and into whatever necessary. Look at that. So this is the yolk sac. You remember yolk sac, and this one sac is called the amniotic sac, and this covering is called amnion. And this is the 2-layer, and gradually changing into 3-layer. And if you do look at that here, you can see the primitive streak here, primitive streak. And at the end of the primitive streak, little bump is called primitive node. And you can see 3 layers now: the ectoderm, mesoderm, and endoderm. Of course, this is the embryonic disc. This would the embryo, the human being will develop from 3 layers. And this ectoderm, it is just spinning around inside. This ectoderm will create cells, and this another group of cells will start from the primitive nodes towards the one end. Look at that. It is the red arrow is showing us here. The cell developed from here to there, to there, there, and then gradually it is the ectoderm. You know, it is ectoderm, which was the epiblast. It is just like trying to do everything, like, and then from the primitive node region towards the one end of the embryo, which is what will happen as the head of the embryo, and it will become notochord. Notochord is going to change into like brain and spinal cord and that sort of stuff, structure, neurological and spinal structures. But this is the ectoderm, which is the driving force from the primitive node towards the head end. So one end of the 3-layer will become head, one end of the 3-layer will become tail, and this is the ectoderm now, which the name changed from epiblast into ectoderm. And this ectodermal cells, we are driving force and creating cells, another cells as a notochord and developing towards the head end. That is going to become the brain and spinal cord and everything. So this ectoderm also will become the brain and spinal cord and neurological structures. And look at the mesoderm. Mesoderm is red color. Let's say because red color, because it is going to become meat, red meat. So all our muscles will come from the mesoderm. And at the same time, the bone, our bone will come from the mesoderm. Hey, big red solid structures at the back of in the retroperitoneal space, which is the kidneys, big block, red colored. These is going to develop from the mesodermal cells. Endoderm, as you can see, endoderm is going to become the inner lining along the gastrointestinal tube. And now I believe you can picture this, 2 little globular structures stacked together here. And in the middle of where they two attach, we have 3 layers. So this one globule, which is the amniotic sac, and the other globule, which is the yolk sac. These 2 globular structures, where it's going to fold from side to side, fold from head to bottom. So like it is, I can't even imagine, you know, this 2 globular change will gradually flatten and then change into head and tail and portion, and from side to side to become the right side and the left side. So 2 globular structures, it is going to fold, and look at that. 2 globular structures are going to fold into the head end and the tail end, and also from this right side and the left side, and going to carve. And by doing so, you know, it is like a 2 balls stacked here, and you have to fold the ball from one right side and left side, from tail end and side, like 2 balls folding. And by doing so, we are creating 2 tubes. One big tube here outside, which is covered with blue, and another tube inside here. So this is what we call inner tube. And this is what we call outer tube. Oh my God, a lot of terminologies. Inner tube. Yes, so you are folding these two big balls into right and left, into top and bottom. And just by doing so, we are getting two tubes, one bigger tube outside, and one smaller tube inside. The smaller tube inside, it's easy to remember, inner tube. The bigger tube outside, let's try to remember the outer tube. Oh, okay. So this inner tube inside our body, what is going to happen? Of course, this inner tube is going to become our gastrointestinal tract from mouth to anus. And of course, the part of this inner tube will develop into our respiratory tract. These are the tubular structures and organs inside our big outer cavity, which is the torso. So which means the outer torso will become our body, tubular structure body, a human being, tubular structure body outside, and the inner tube will become the gastrointestinal tract, any tubular structure like respiratory tract. And this inner tube is called, because it is going to become the gastrointestinal tract, and therefore, let's give it a name, primitive GAT. Yeah, so GAT, gastrointestinal tract, primitive early gastrointestinal tract. So yes, it is so difficult. Like if we have to make a human being by ourselves, it like a car, making car, it will be so difficult. Like it's just try to fold from right to left, from top to bottom, and this big things will gradually become two tubes, outer tube and inner tube. And inner tube is become the tubular structure inside our body, which is the gastrointestinal tract, respiratory tract. The outer tube is become our torso. Yay! So getting there now, we are creating a human being, and let me keep you about another 2-3 minutes. And this, look at that, the head end and the tail end gradually fold, and it is gradually swallowing the yolk sac, as you can see, gradually swallowing the yolk sac, and gradually swallow more and more. The yolk sac become smaller and smaller and become more like an elongated structure, which is what we call the placenta cord, and look at that, gradually become the yolk sac here will become the part of the gastrointestinal tract. And now this folding from the head end and top end will gradually become like a little human being. Hey, we have a little human being already. And now just the yolk sac being swallowed, the different picture and diagram. Hey, now finally, because of the folding from right to left and head to bottom, we have the two tubes, outer tube and inner tube. Outer tube, and the same thing like a tubular structure here on the arms. It is like but there is no tube inside. So in the limbs, it's become like that. The outermost covering, which is blue is the ectoderm, which we develop into skin. Inner red color, muscle, and the bone here in the limb, they will derive from the mesoderm, red color, mesoderm, and there is no endoderm in the limb. So there is no endodermal derivatives in the limb. And the whole body, outer tube and inner tube will develop into gastrointestinal tract, respiratory tract. Outer tube is going to become our torso, body, and the outermost covering is blue, ectoderm. So our skin, look at the skin, epidermis and dermis develop from the ectoderm. All our muscles, so bone, muscles, kidney, red in color, the smooth muscles, striated muscle, they will all develop from the mesoderm. And inner tube, look at the inner tube here, lining of the inner tube, which is the endoderm. the lining of which will become the lining of the gastrointestinal tract. Right, so now we have a little baby. Now we have a little baby by folding right and left, folding top to bottom. We create two tubes, one big tube, outside big tube, and small inner tube. Right, guys, so I'm going to stop here. I'm going to stop here. I believe you guys, because it's bone here, it is bone here. So this is the pelvis, human pelvis. The pelvis with the sacrum, we form the pelvic girdle. The pelvic girdle, as you know, the flat bone on one side, each side is called ilium. The spelling is I-L-I-U-M. The ilium, duodenum, jejunum, ilium is I-L-E-U-M. Ilium. So this is the ilium, is the flat bone on one side here. And if this is what we call the dome shape of the ilium bone, which is called iliac crest. Yeah, iliac crest, going dome shape and dome shape here. And at the anterior end, the dome shape, the iliac crest, and as a pointy bony portion, that is what we call anterior. It is in the front, it is not in the back. Superior, because it is above, because we have the inferior, lower one here. Iliac spine, yeah, that is the spine of the ilium, iliac spine. It is in the front and it is is the upper one, anterior superior iliac spine. Yes, and then the bone go back in and come back out again, another pointy bit, which is what we call anterior inferior, because this is superior above, this is below, so inferior, anterior inferior iliac spine. So these are the anterior superior iliac spine and anterior inferior iliac spine. Iliac crest, ilium, and this is the sacrum, you know that. And the junction between the sacrum and ilium is called sacroiliac joint. Of course, two bones meet. That is what we call sacroiliac joint. And you can see the sacrum here at the top, at the bottom, you will see the coccyx. And the pelvis bone is made of three main portions. Number one is ilium, and number two is, look at that pubic bone. Pubic, this is at the top, this is the bottom. So this is the pubic rami, just in the rib, superior pubic rami and inferior pubic rami. The inferior pubic rami will go backwards and downwards and become a big bony bump, which is what we call ischium. So now ischium, pubic, and ilium make the pelvic bone, and right pelvic bone and left pelvic bone together with the sacrum, we build the pelvic girdle. So I want you to remember pubic, superior pubic rami, and lower one, this is the superior pubic rami, lower one is inferior pubic rami, and superior pubic rami, inferior pubic rami. Ischium is the bony bump here, which we are sitting on. We are sitting on the ischium. So let's say if you poke somebody's buttock with your finger, and you will see a bony bump here on one buttock. So this is the ischium, and if we are sitting, we are sitting on the ischium. And this is the femur, proximal femur. This is the greater trochanter. This is the lesser trochanter. This is the femoral neck, and this is the femoral head. Yeah, so femoral head joins with the pelvic bone, which is called the acetabulum. Yeah, the socket portion of the femoral hip joint, which joins the femoral head, that is called acetabulum. So acetabulum and femoral head. So acetabulum is the portion where the pubic bone, ischium, and pelvic bone meet all together. Right, and you remember the pubic symphysis, which is in the middle, right pubic bone and left pubic bone meet in the center. That is what we call pubic symphysis. That is in the very center. Hey, if you follow the superior pubic rami, and if you want to come along the pubic symphysis, you can see a little bony notch here. That little bony notch to tubercle, isn't it? Trochanter, we saw the greater trochanter, lesser trochanter, greater tuberosity, lesser tuberosity in the proximal humerus. So this little bony bump is called, because it is in the pubic bone, so we will say pubic tubercle. That little pubic tubercle is going to give attachment to the muscles. So I want you to understand this pelvic anatomy, and I believe you do. Anterior superior iliac spine, anterior inferior iliac spine. You can easily feel your anterior superior iliac spine. It will be very difficult to feel the anterior inferior iliac spine. You can feel the iliac crest, and that is the ilium. Pubic bone, pubic symphysis, you should be able to feel it. Ischium is a bony bump in the buttock where you are sitting on it. And I want you to appreciate this little pubic tubercle, which is just slightly off from the pubic symphysis. It's a little bony bump. That is what we call pubic tubercle, because the pubic tubercle is going to give a few muscle attachment. So, bang, hey, what are these? These are the muscles of the abdomen. External oblique, internal oblique, and transversus abdominis. You know that, you know this already. This is the muscles of the anterior abdominal wall, external oblique, internal oblique, and transversus abdominis. In the middle, we have the rectus here. Yeah, so let's not go to the rectus yet. So the origin and insertion of these anterior abdominal wall muscle, they are slightly important. And it is easy to remember. So external oblique, internal oblique, and transversus abdominis. Look at that. The outermost layer, external oblique, you can see where is it coming from. Hey, it is coming from the ribs, guys. It is coming from the ribs. And it is going to it's finally become, aponeurosis. So that's what we remember. So it is originating from the ribs, and it is going to the middle to become the rectus sheath, and finally meet in the linea alba with the opposite. So that is the external oblique. So I believe you can make a guess about origin and insertion. Origin coming from the ribs, and insertion, it will go to the aponeurosis, rectus sheath. Let's look at that. The external oblique is origin from the lower 8 ribs. Insertion go into the linea alba. That is what we have seen. And it will go to into the pubic crest and pubic tubercle. That's pubic tubercle here, and iliac crest. So now it is pretty easy to remember the origin and insertion of the external oblique. Yeah, it is coming from the rib. It will go to the pelvis. It will go to the pubic tubercle, and it will become a what you call aponeurosis and rectus sheath, and meet with the opposite side in the center, which is linea alba. So what about the internal oblique muscle here? So what do you think it is originating from? Hey, it can be originating from the ribs, and it might be originating from the iliac crest, where is it going to? Hey, it's easy, isn't it? Every anterior abdominal muscle come to the center to form the rectus sheath, and finally combine with the opposite side. Combine with the opposite side to in the linear elbow. So combine with the opposite side, so linear elbow. So you mean if you look at that, its origin could be from the ribs, or could be from the iliac crest. Well, let's look at that, what the book say. So internal oblique here, origin O is from the inguinal ligament, okay. Iliac crest, we saw that, and lumbar fascia. Lumbar fascia is from the very back in the leg, latissimus dorsi, all the lumbar fascia. And it will meet in the center, linear elbow, not a difficult things to remember. And it will go to the last 3 or 4 ribs in the costal margin. Oh, okay, so it is originating from the iliac crest. It is originating from the posterior lumbar fascia, and it is going to the lower 4 ribs, and it is going to the aponeurosis and become linear elbow. Okay, so that is the internal oblique muscle. As we say, external oblique is downwards and medially. Internal oblique is upwards and laterally. Yeah, so that is the internal oblique. What about the transversus abdominis? Transversus abdominis has the similar pattern, isn't it? Let's look at what it is written. Transversus abdominis muscle here. It is originating from the inguinal ligament and lumbar fascia. It is the same like the internal oblique, and it goes to the center, linear elbow and pubic crest. So hey, finally, whatever we say, everything is similar. It is from the rib, it is from the iliac crest, and it is going to the center, linear elbow. These are the origin and insertion of the anterior abdominal wall muscle. Why am I talking about these anterior abdominal wall muscle at this stage? Because we have to know the inguinal ligament. Here they have written here inguinal ligament, and oh my God, why this inguinal ligament is so important? Inguinal ligament is in the inguinal region, and when we talk about the inguinal region, and we have to talk about the inguinal canal. Oh my God, what is inguinal canal and what is inguinal ligament? So it is pretty simple. So the external oblique, what is the inguinal ligament? The inguinal ligament is the lowest portion of the external oblique muscle. If you remember like that, things become easy. So let's say this is the external oblique aponeurosis, external oblique muscle, which is coming down from the ribs, coming down towards the medially, and it folds inside. Yeah. So it is folding inside. So this is the external oblique aponeurosis, which is the outermost layer of the muscles of the abdomen, anterior abdominal wall. And when it gets close to the pelvic bone, it will become folding inwards. And this fold is become thickened as well. And this fold is called inguinal ligament. Oh my God, that's easy. So inguinal ligament is nothing more than the inferior border of the external oblique aponeurosis. We'll leave the rectus muscle. I will just leave it as it is because it's just for completeness. And I want to show you the anatomy of the pelvic bone. Of course, it is a little bit more more in detail comparing to our previous pelvic bowl. But have a look, it is easy. And pubic tubercle is, pubic symphysis is here, pubic symphysis is here, and here pubic symphysis, and this is the little bony notch which we were talking about, pubic tubercle. So because inguinal ligament come and attach to the pubic tubercle, that's why we have to know the pubic tubercle. And let's look at the anterior abdominal wall again. Let's look at the anterior abdominal wall again. This is the external oblique aponeurosis, which is the outermost, which is coming downwards and medially. The external oblique aponeurosis is originating from the lower ribs, and it will come and attach to the ilium, and at the lower margin, so in the center, it will become aponeurosis. We all know that, to form the rectus sheath. And at the lower margin of the external oblique, which way, as I say, the external oblique muscle is here. At the lower margin, it will fall like that. It will fall like that. It will fall like that. Hey, look at that. It will fall like that. The external oblique muscle, it will fall inside, and it will the fold portion is attaching the tip of the anterior superior iliac spine and going to the pubic tubercle. That is what we call the inguinal ligament. And I believe we all remember this diagram from the gastrointestinal tract. So the three layers, external oblique, internal oblique, and in transversus abdominis. So these three layers, when it comes close to the center, the muscles become aponeurosis or fascia. The internal oblique fascia will split into anterior and posterior. Anterior portion will combine with the external oblique aponeurosis. Posterior portion will combine with the transversus abdominis to form the rectus sheath, anterior rectus sheath, posterior rectus sheath, and meet in the center with the opposite rectus sheath, and that is what we call linea alba. That is the anatomy we know. And if you just getting a little bit closer, then the external oblique muscle, internal oblique muscle, in the near to the center, they will become aponeurosis. As we say, like, the external oblique will fuse with the anterior layer of the internal oblique. Transversus abdominis will fuse with the posterior layer of the internal oblique. They form the rectus sheath, meet in the center. And this was what we were talking about when we were talking about the gastrointestinal tract. Yeah. So, but does it happen everywhere? Does it happen everywhere? No, there is some exception. So that is the diagram here, the external oblique, internal oblique, and transversus abdominis. Internal oblique split into two layers, anterior and posterior. Anterior will bind with the external oblique aponeurosis to become the anterior rectus sheath. The posterior division will fuse with the transversus abdominis to form the posterior rectus sheath. Posterior rectus sheath and anterior rectus sheath, they will enclose the rectus abdominis muscle. And inside, there is a little fascia, which is the deep fascia. That is what we call transversalis fascia. I didn't include that when we were talking about the abdomen of the gastrointestinal tract, because it is too much. But now I'm going to introduce you the little fascia. This is just a thin and flimsy fascia, which is what we call transversalis fascia. Don't confuse with the transversus abdominis. So this is one layer which is covering here, and only after that we have the peritoneum. Look at that. So this is the anterior abdominal wall. But this splitting, like trying to envelope the rectus sheath, does it occur all along the rectus from the Xiphi sternum to the pubic symphysis? Does it occur from top to bottom, from here to down there? No, it is not. So this sort of splitting and enveloping the rectus cover only from the Xiphi sternum down to the somewhere around here. So it is a point where, roughly speaking, between the umbilicus and the pubic symphysis, so halfway between umbilicus and the pubic symphysis, halfway here. And this area, this line is called arcuate line, A-R-C-U-A-T-E. So from arcuate line to above, all the muscle split and envelope the rectus. But below the arcuate line, A-R-C-U-A-T, arcuate line, which is the midpoint from the umbilicus and the pubic symphysis, all these three layers, they do not enclose the rectus. Every muscle and aponeurosis go in front of the rectus abdominis. So let me show you here. So hey, this is the arcuate line, yeah? Arcuate line, it is the line where all the three layers envelope the rectus abdominis. Below the arcuate line, all these fibers go in front of the rectus muscle. Look at this, you know, this is the right rectus, this is the left rectus, this is the external oblique, internal oblique, and transversus abdominis, external oblique, internal oblique, and transversus abdominis. The green color is called transversalis fascia, and the yellow color is called peritoneum. And these three muscles, external, internal, and transversus abdominis, they will split and they will envelope the rectus abdominis and meet with the opposite side in the linea alba. But below the arcuate line, A-R-C-U-A-T, below the level arcuate line, which is the somewhere in the midway between the umbilicus and the symphysis, in the midway, at that level, all the muscles, they change their mind and they go in front of the rectus muscle, and on the posterior aspect of the rectus, below the arcuate line, we only have the green, which is the transversalis fascia. So, you know, below the arcuate line, the rectus is not enveloped in the rectus sheath. We only have anterior rectus, but below the arcuate line, we have the transversalis fascia, which is lying in between the peritoneum and the rectus. So it's a human body, you know, like there are a few little exceptions, but it is interesting. Why did this happen? I'm not sure why, but above the arcuate line, all these muscles split and then envelope the rectus from front and back. But below the arcuate line, these muscles will go just only in front of the rectus. They do not split and go to cover the posterior aspect. That is the arcuate line, and that is the structure of the anterior abdominal wall. These are little things which is important with time and time and time. So this is the anterior abdominal wall structure. So look at that. I believe you have seen this diagram already if you have done the homework. External oblique coming from the ribs, going to the ilium and meet with the opposite side in the linea alba. Internal oblique, it is arising from the iliac crest, arising from the inguinal ligament, arising from the posterior lumbar fascia, going to the rib, going to the center, like making an envelope for the rectus sheath, meet in the linea alba, and transversalis fascia, pretty similar to the internal oblique as well. The fibers are going horizontally. And you can see the rectus muscle here. Rectus muscle above the arcuate line from xiphisternum to the arcuate line. It is enveloped with the aponeurosis of the three muscles of the anterior abdominal wall. But below the arcuate line, these three muscles of the anterior abdominal wall just go in front of the rectus. They do not give any protection in the posterior aspect, and the only layer is transversalis fascia, which is lining in between the rectus and the peritoneum. So because, you know, why I have to talk all these, this is because like when it comes to the inguinal region and inguinal canal, like all these knowledge will help us. So are we brave enough to go to the inguinal canal? Yes, we are. Yeah, let's go to the inguinal canal. Just try to explore the inguinal canal a little bit and try to grab as much as we can. So now I'm just keep showing you again and again and again and again. This is the outermost layer, which is the external oblique muscle. This muscle close to the center, it will become aponeurosis of the external oblique. And at the lower inferior margin, it will curl up and roll up to become the inguinal ligament. We can see that inguinal ligament here, inguinal ligament here. So coming from, and this is the external oblique. Internal oblique, look at that. Internal oblique come here as well. And because it is close to the pubic symphysis, so it is below the arcuate line. And this is the transversus abdominis muscle. Look at that. And they were all fused and go in front of the rectus muscle. You can see that this is the red is rectus. What is the transversalis fascia? Fascia transversalis. This is light gray, pale color. It is coming here. It is becoming the posterior covering of the rectus. All the three layers above the arcuate line, we envelope, we grab, go from both front and back. But below the arcuate line, all these muscles go in front of the rectus. And look at that, look at that, look at that. So this external oblique, internal oblique, and transversus abdominis and fascia transversalis. Yeah, don't confuse between fascia transversalis and transversus abdominis. Fascia transversalis is one layer before we get to the peritoneum. And if you look at these three layers fused in front, and this external oblique roll up and curl up to become the inguinal ligament. And when it comes to the attached to the pubic tubercle, this inguinal ligament or external oblique muscle, they just split like that. They just split and come and attach to the pubic symphysis and pubic tubercle region. By splitting into two, they create a hole, which is what we call the external ring of the inguinal canal. So yeah, so now you can see this aponeurosis of the external oblique, inferior margin roll up to become the inguinal ligament. The inguinal ligament with the external oblique aponeurosis, when it comes attached to the pubic tubercle region, they do split like that and attach. By splitting, it is creating a hole, and through the hole, there is some structures will be passing through the hole. That is what we call the external ring of the inguinal canal. Bang, let's go. Let's move on to next slide. So look at that. It is so pretty. This diagram is so good. This is the outermost layer of the anterior abdominal wall muscle. This is the external oblique aponeurosis. External oblique aponeurosis gradually come towards the center. The muscle will change into aponeurosis. This aponeurosis rolled and curled up here, and trying to attach to the pubic superior pubic rami, try to attach to the pubic tubercle, and By splitting like that, splitting into two, it is making a hole. This hole is called external ring. This is a little ring in the, which is a defect in the external oblique aponeurosis. That ring is called the superficial ring of the inguinal canal. So you can see this now. I believe you are clear already. External oblique muscle became the external oblique aponeurosis. This aponeurosis collapsed to form the inguinal ligament. Inguinal ligament is running from the anterior superior iliac spine, going to the pubic tubercle, and it is a roll-up and collapse structure. Part of the external oblique muscle goes straight to the more towards the pubic symphysis, and by making arching, splitting like that, it is creating a hole. This hole is called superficial inguinal ring. So there will be structures which will be coming out through the superficial inguinal ring. Right. So if we remove the external, this is the external oblique. So we have to remove the external oblique. And now we can see the internal oblique muscle here. Internal oblique muscle here. As we know, internal obliques, they are coming from the iliac crest. They are coming from the lumbar fascia. They will be going to the ribs. They will be coming to the center to form the rectus sheath and meet with the opposite side in the linea alba. Look at the direction of the internal oblique muscle. And this internal oblique is stuck to the posterior wall. So let's say this is the external oblique. This internal oblique, which is the inner layer, at the outer 1/3, it is stuck to the posterior wall of the external oblique, and it just go arch, and then go to the back of the, go and fuse with the external oblique tendon here, and that makes the conjoint tendon. Look at that. Meet in the, so this is where the conjoint tendon is. So the inner, if we remove the external oblique, we have the internal oblique, which will just start from the outer 1/3 of the inguinal ligament and go and arch and form the inner aspect of the external oblique. That is what we call the conjoint tendon. So now, Cooper's ligament, look at that, the innermost portion here, the Cooper ligaments here. Let's try to forget about that and let's move on. So this is the left view. This is the left view. I'm sorry because I was showing you the right side of the inguinal canal. Now I have to show you the left side of the inguinal canal because this picture is so good. This picture is so good because now I have removed the internal oblique. Get the internal oblique, obliquus internal. So internal oblique being split to see the transversus abdominis muscle. Look at the transversus abdominis muscle as well. Look at the transversus abdominis muscle, and it is coming from the, like an internal oblique, but it is going here medially. It will contribute to the rectus sheath, but it is coming towards the pubic tubercle again, close to the pubic tubercle again, but it is coming from the back, and it's just stuck to the wall of the internal oblique muscle. So these three muscles stack on each other and trying to make it stronger to become the tendons and ligaments here. So this is the transversus abdominis muscle after being cut away the what you call the internal oblique muscle. Now it is coming like an arch shape. It's arch shape, yeah. So we can see that. Now I am going to show you that this is the rectus muscle here. I'm going to show you a little green triangle area. Look at that little green triangle area here. This triangle is called Hasselbalch triangle. So Hasselbalch Hesselberch. It will be in the later slide. This green color is called Hesselberg triangle. What is the boundary? What are the boundaries? Boundaries are the one end is rectus marsa, the other end is inguinal ligament, and the other boundary is the inferior epigastric artery. So this is the little green triangle, which is formed by the inferior epigastric, rectus, and the what do you call that, this inguinal ligament. So this green is called Hesselberg triangle. Don't worry about that, we came in the later slide. Now I want you to appreciate again, you know, I'm not going to keep you too long. Just try to concentrate, because I know it is like too much, but it is, as an anatomy student, we have to know our abdomen and we have to know our inguinal region, and we can see the external oblique, internal oblique, and we can see transversus abdominis, 3 muscle, and this is going behind the rectus, and therefore this must be the transversalis fascia, external oblique, internal oblique, transversus abdominis. They will all fuse to in front of the rectus abdominis muscle. Here, posterior to the rectus is only the transversalis fascia, which is here. And look at the fibers here running external oblique, which is going to the pubic tubercle, and which is as forming a little splitting like that. By splitting, it is forming like an arch and going to the pubic symphysis, going to the pubic tubercle, and it creates a little defect. This is the superficial inguinal ring. And internal oblique, which is on the outer 1/3, lateral 1/3 of the inguinal canal, it is stacked to the external oblique, and internal oblique are stacked. So, and the middle 1/3, this external oblique will go join here. This internal oblique will be joined by the transversus abdominis muscle here on the medius 1/3 of the posterior part of the inguinal triangle. And this inguinal canal in male is going to transmit the spermatic cord. In female, the inguinal canal is going to transmit the round ligament of the uterus. So I know it is still not very clear, but keep saying again and again, just keep holding like that. And now finally, you know, in male, the inguinal canal is going to give us a route for the spermatic cord, which will go into the scrotum. And this is the superficial ring, which is the that's the importance of the inguinal canal and hernia. We talk about that. So I have been talking for the whole morning about inguinal. What do I mean by inguinal? So inguinal canal and spermatic cord. Inguinal canal, it is a canal. It is a canal which is originating from the inside the abdomen. So it is like a canal here. It is like a canal here, inguinal canal, which is coming from inside abdomen, transversalis fascia to outside, and we come into the scrotum. So that is why, you know, we have to understand about inguinal canal, because when you become a surgeon, like if you want to do operation on the inguinal region or hernia, this is the anatomy. Yeah, I know, you know, it is too much. In this inguinal region anatomy, you have to do as a medical student, you have to do as a postgraduate student, you have to learn when you are becoming the fellow or the residents. You know, it is like, you know, every step. That means like they know that we don't really understand or we can't remember this inguinal region. Therefore, we have to teach the residents and fellows again and again about inguinal canal. So if we do not have a little grip little grip about inguinal canal, then we will not be able to proceed. Therefore, we have to know the little grip about the inguinal canal. After this slide, I'm going to stop. I know, it's too much for you guys. So inguinal canal and the spermatic cord, because inguinal canal in May, it transmits the spermatic cord. Inguinal canal anterior wall is made of external oblique, and in the lateral third, internal oblique. Posterior wall of the inguinal canal, of course, we have the transverse internal oblique and transversalis fascia, because it is in the back, and internal oblique and transversalis fascia, internal oblique and transversalis abdominis will form the conjoint tendon. The roof, which is the arching fiber, because the internal oblique is on the lateral side, it is stacked to the external oblique. On the medial side, it is stacked to the posterior wall, transversus abdominis. Therefore, it is forming as a roof. And floor is inguinal ligament, lacunar ligament, iliopubic ligament, it is the same. Superficial ring is in the external oblique, lateral to the pubic tubercle, and deep ring is in the transversalis fascia. So this transversalis fascia is like something being pushed to come into like that. That is the transversalis fascia. So I'm going to stop here, guys. So I hope, it is not too much. We will talk again about the inguinal canal when we meet on Friday. And